Ladies and gentlemen, I would like to welcome the arrival of the Associate Deputy Vice-Chancellor for Academic and International Matters, Professor Yvonne Lim Ailian, accompanied by Professor Mary Joseph Marret, Professor of Pediatrics, Faculty of Medicine, University Malaya. If I may invite you to take a seat, Professor Yvonne, Prof. Mary, along with the audience. Assalamualaikum warahmatullahi wabarakatuh. Salam sejahtera diucapkan kepada semua hadirin yang dihormati sekalian. Selamat datang ke Syarahan Perdana Profesor Mary Joseph Marret pada hari yang berbahagia ini. Hadirin sekalian, izinkan saya meneruskan acara ini di dalam bahasa Inggeris. Ladies and gentlemen, I would like to extend our warmest welcome to Yang Berusaha Professor Yvonne Lim Ailian, Associate Deputy Vice-Chancellor for Academic and International Matters of University Malaya. Yang Berusaha Professor Dr. Mary Joseph Marret, Professor of Pediatrics, Faculty of Medicine, University Malaya. Dean of the Faculty of Medicine, University Malaya, Yang Berbahagia Profesor Datuk Dr. Yang Faridah Abdul Aziz. Yang Berbahagia Tan Sri Professor Emeritus Muhammad Amin bin Jalaluddin, former Vice-Chancellor University Malaya. Yang Berusaha Dr. Farahnini Dusuki, Chief Children's Commissioner, Human Rights Commission of Malaysia, Suhakam. Management of Faculty of Medicine and University Malaya Medical Center, distinguished guests, professors, doctors, ladies and gentlemen, who are joining the inaugural lecture virtually and physically today to this very special event hosted by the Faculty of Medicine, University Malaya. I am Dr. Amanda, and I'm honored to be the Master of Ceremonies for the inaugural lecture of my lecturer and colleague, Professor Mary Joseph Marret. A professor's inaugural lecture is one of University Malaya's cherished traditions. This lecture honors the professional journeys taken by our professors and provides an opportunity for them to share their wisdom, inspiration, and philosophies. We are grateful to be here for the inaugural lecture by Professor Mary Joseph Marret, Professor of Pediatrics, Faculty of Medicine, University Malaya. Today, Professor Mary will be sharing her journey in this inaugural lecture entitled Listening to the Voiceless. Ladies and gentlemen, without further ado, I would like to invite the Associate Deputy Vice-Chancellor for Academic and International Matters, Professor Yvonne, to chair the lecture and introduce Professor Mary. Please welcome.
Young Barusa Professor Dr. Mary Joseph Marret, Professor of Pediatrics at the Department of Pediatrics, Faculty of Medicine. Yang Berbahagia Professor Dr. Yang Farida Abdul Aziz, the Dean of the Faculty of Medicine, University Malaya. Yang Berbahagia Tan Sri Professor Emeritus Dr. Muhammad Amin Jamaluddin, our former Vice Chancellor and a professor at ENT, Faculty of Medicine. We also have Yang Barusa Dr. Farah Nini Dusuki, Children's Commissioner, Human Rights Commission of Malaysia, Suhakam. I'd like to also acknowledge Dr. Professor Christopher Boy and our many colleagues, management of the Faculty of Medicine, University Malaya Medical Center, and many professors that I know, Professor Lucy, and many others. It's really good to be here. Professor Lee, yeah, very good to be here. Distinguished guests, professors, doctors, ladies and gentlemen. I feel very privileged to introduce Professor Dr. Mary Joseph Marret, a dear friend and colleague. Professor at the Pediatrics, Faculty of Medicine, University Malaya. She began her medical journey at the National University of Singapore, graduating in 1988, and went on to complete her specialist training in pediatrics. She obtained her MRCP from the UK in 1993 and was later elected Fellow of the Royal College of Pediatrics and Child Health. She joined University Malaya in 1996, was promoted to Associate Professor in 2007 and Professorship in 2019. For more than 2 decades, she has led the Division of Community Pediatrics and served as a senior consultant at University Malaya Medical Center. She has supervised over 20 postgraduate students and coordinated postgraduate training in her department. Importantly, she was one of the pioneer coordinators when the MRCP-CH clinical examinations was first conducted in Malaysia in 1997 and has continued to serve as examiner both locally and internationally. In medical education, Professor Mary has played a central role in shaping the University Malaya medical program since its introduction in 2013. She contributed to curriculum development, served as faculty advisor for clinical assessments, and together with colleagues, helped redesign assessments during the COVID-19 pandemic to ensure students graduated without disruption. I think many of us, would have that experience of COVID-19, and one of the most challenging thing is actually assessment. You can teach online and all, but converting assessment into something online is not an easy feat, and Prof. Mary did it. So for her contributions, she was recognized with the Faculty of Medicine's Inspire Award in 2025. Now, beyond the university, she has been a tireless advocate for children protection. She chairs the Child Protection Committee at UMMC and co-chairs the Malaysian Pediatric Association's Child Protection Subcommittee. She leads a multidisciplinary team caring for vulnerable children and has been invited by hospitals, universities, NGOs, UNICEF Malaysia, government agencies, and the World Health Organization to provide expertise on laws, policies, and service provision. She also contributed to WHO guidelines on the health sector response to child maltreatment. Professor Mary also pioneered developmental pediatric services at UMMC in the late 1990s, paving the way for today's Child Development Center that provides vital support for children with disabilities and development challenges. Her research focuses on children or child maltreatment, adolescent victimization, and abuse-hate trauma, with findings published in journals and book chapters and presented at international conferences. She has also reached the public directly, writing on child health in parenting magazines and the local media. Outside of a professional life, she's very passionate about music and creative writing. She's actually very poetic. I remember once when I was transferred to Central, one day I got a parcel from her. And when I opened the parcel, I was pleasantly surprised. Writings that I actually look forward to read every day. And so thank you so much, Mary, for that. A person who not only observes, and I think if you know Mary, she's a very reflective person. She reflects deeply and often uses these ways to reflect on her encounters with the children. So with such a distinguished career, dedication to children, especially those most vulnerable, it is truly fitting that you have chosen the inaugural lecture today to be titled Listening to the Voiceless. So ladies and gentlemen, please join me in welcoming Professor Mary Joseph Marret.
Thank you for the kind introduction, Prof. Yvonne. Distinguished guests, colleagues, and ladies and gentlemen. As a pediatrician, we depend on parents to bring their children when they are ill or when they have suffered an injury. And we rely on the information they provide to make a diagnosis. However, in the case of children who have suffered violence, they may not always be brought for medical attention. And what we are told by parents and caregivers may be misleading or omit important details. The children themselves may not have the verbal capacity to reveal to us what has happened. They may be silenced, or what they say may sometimes be ignored or dismissed. The problem of violence against children has been with us for centuries. In what is perhaps the first textbook of pediatrics written by a Persian physician in the 10th century, there is a mention of intentional injuries against children. In the 19th century, a French forensic physician by the name of Dr. Ambrose Tardieu wrote extensively about his experience of seeing injuries in children who had been physically and sexually abused, about infanticide, and about the detrimental effects of health on children who were working in mines and factories. But at that time, the medical community did not take much notice. And it was about a century later when an American pediatrician by the name of Dr. Henry Kemp wrote a paper entitled The Battered Child Syndrome that the medical community and the community around began to acknowledge the problem of child physical abuse. Even then, it took another decade before doctors acknowledged the reality of child sexual abuse. So why did this take so long? So one of the reasons is that in the past, children did not have a status in society. They were not considered to have a distinct or separate identity apart from their parents. And therefore, they were not recognized as individuals entitled to rights. Children who are very young or children with difficulties with speech have difficulty communicating their experiences and problems. There was also views in the past, and sometimes even to the present day, that how parents punish their children is a private family matter, and so people are reluctant to interfere. There is also a tendency to have an inherent bias so that when there are conflicting accounts of a child's injuries between what an adult says and what the child says, there is a tendency to believe the adult despite what the evidence shows. People also had difficulty coming to terms with the possibility that parents who were supposed to be loving and caring for their children could sometimes harm them. So this legislation, the UN Convention on the Rights of the Child, which came about after the work of Henry Kemp and many others, is quite a radical legislation because it finally recognizes children as individuals who are entitled to fundamental rights without discrimination, and it defines a child as an individual under the age of 18 years. And it's only when this problem is acknowledged that people began to study the problem and its impact on children, and therefore medical knowledge regarding child maltreatment is only decades old compared to a lot of other diseases like tuberculosis or leprosy, where the knowledge is centuries old. A study commissioned by the UN Secretary General to look at globally at violence against children found that there is no country in the world, rich or poor, where children do not experience violence. They experience different types of violence in the home as well as settings outside the home, inflicted by their families and people that they know, people who have authority over them, and also sometimes their own peers. This affects children of all ages, of different genders, regardless of race or religion, but some groups of children may be particularly vulnerable because of a disability or because they're targeted because of their gender or their race or their beliefs. We use the term child abuse or maltreatment when we refer to violence inflicted by adults entrusted with the care of children, such as parents, family members, or other caregivers. However, it's important to keep in mind that this is only one form of violence that children face, and they may also experience a whole range of different types of violence in the community, all of which have an impact on them. So the first reports of child abuse in the medical literature came from this institution, this hospital, then known as University Hospital, in the 1970s. And following this, there were initiatives to establish a multidisciplinary team of doctors, social workers to manage this problem. Across town in the Kuala Lumpur General Hospital, there were also similar initiatives led by Professor Datuk Muhammad Sham Qasim and his team, which called their multidisciplinary team the Suspected Child Abuse and Neglect Team, or SCAN team, the acronym by which we know such teams in the present day. But even then, it was only those doctors who were dealing with the problem who had an awareness of this, and there was no law mandating reporting child abuse, and therefore doctors outside were generally reluctant to refer such cases. It was in 1990 when the media published news reports of the tragic death of a 15-month-old boy by the name of Balasundram, whose body was found dumped in a dustbin in Hospital Kuala Lumpur. He had suffered terrible injuries due to physical and sexual abuse. He was barely alive, rushed to the ICU, but his life could not be saved. And this is the point in which Malaysia woke up. And this led to legislation about child abuse, starting with the Child Protection Act in 1991, following which one-stop crisis centers were established in the emergency departments of public hospitals so that families of children who had suffered violence, victims of domestic violence, as well as adult survivors of sexual assault could easily access medical attention as well as make reports and seek shelter and protection. The initial Protection Act was subsequently repealed and replaced by a more comprehensive Child Act 2001. And in the formulation of this act, I believe that the law faculty of University Malaya played a key role. And in this law, it provided a framework for police, welfare officers, and doctors to work in cooperation, where children suspected to have been abused could be brought to hospital to get medical attention, and subsequent interventions could be made for their protection. In more recent times, another piece of legislation, the Sexual Offences Against Children Act 2017, has been added to better cover a range of sexual offences, including emerging offences such as sexual grooming and online sexual exploitation. So it's against this background that I joined University Malaya in 1996. And prior to this, in my 8 years of working experience, I'd seen probably a total of 3 cases of child abuse. So I had a great deal to learn in a service that was probably seeing about 15 to 20 referrals a month at the time. I was guided and taught by this mentor, the late Puan Sri Professor Rebecca George, who was at that time the chairman of the Hospital Child Protection Committee and head of the SCAN team. Quite early on in my career there, about 3 months into the job, I was thrown into the deep end. I was asked to present a paper which was a retrospective review of cases of sexual abuse seen at the university hospital over the past few years. And this was at a conference which was organized by the Hospital Child Protection Committee, as well as INSAN, which was the service which provided intervention for adult survivors of sexual abuse. So this was a very useful orientation for me because I had the chance to meet others from other institutions in the country and various agencies who were working in the field, and listening to their presentations, I had the opportunity to have a better understanding of the many challenges there were in providing such services, and also got a sense of the collective frustration on the ground when things did not work smoothly. So less than 2 years after I came, Professor Rebecca George retired. So then I was left without a senior mentor in the university and the hospital to actually guide me to build up my knowledge base and understanding. So I reached out to pediatricians from the Ministry of Health who were working in this area, notably Dr. Irene Chia and Dr. Amar Singh. I also became a member of this International Society for the Prevention of Child Abuse and Neglect, or IPSCAN. And this society does not consist merely of medical doctors. The membership includes mental health professionals, legal experts, people in the field of social work, education, and public policy. So through attending conferences that they organized, as well as courses and presenting papers, meeting international experts in the field, I was able to expand the depth and the breadth of my knowledge. So just as you start to get a little bit comfortable, somebody will pull the rug from under your feet. So this happened when somewhere in the mid-2000s, I was appointed chair of the Child Protection Committee. And this was a period of transition when we moved from the old to the new legislation, the Child Act 2001, and we had to conform to its requirements and provisions. By that time, I discovered that I was the only person left in the Child Protection Committee that I joined in 1996. So everyone else from the fields of obs and gynae, psychiatry, social work, even nursing, everyone had been replaced. And the new staff were not very sure what to do. And this was a time when we were getting more referrals of more complex cases. So then what I did was to lead the committee in drawing up a set of guidelines so that there would be better clarity of what to do and how to do it. And then we proceeded to run a series of in-house training courses for our staff across different disciplines so that there would be a better understanding of how these guidelines worked. And these are courses that we continue to have to this day yearly. And this helps to address the problem of sustaining a service when there is constant staff turnover. So it was not just the doctors who were facilitators, but we also engaged our social workers as well as senior nursing staff. And at that time, Dr. Priya Chandran, who's I'm very happy is here today, was also helping me out in the SCAN team. And we made the courses very, very interactive with a lot of activities and role play. And this is really important when you're trying to teach people very abstract concepts such as child rights, and to make sure that they understand the need to be very sensitive in their dealings with children who had been traumatized, and to also work in cooperation with staff from other clinical areas, which doesn't always happen naturally. And this is really important for smooth and safe handover of children between different clinical areas. So now this little miniature Play-Doh models that you see on the screen were made by a child who is nonverbal due to a developmental problem, but the intricate details that you see tell us about how she sees the world. And this leads me to talk about how I was involved in the development of services with another group of voiceless children, those who are disabled and have developmental problems. So in my first few years in I discovered that services for this group of children was rather fragmented. And they would receive care for the obvious visible problems, which were usually some kind of surgical treatment. And then the other hidden problems would not be addressed. So I remember many years ago receiving a telephone call from a person that I'd never met before. And that was Dr. Tunku Nortaya, who's a rehabilitation physician. And she was actually requesting me to see one of her patients in my afternoon clinic because she'd just seen this child with cerebral palsy in her morning clinic, and the child had thrown a seizure in her clinic. And then she discovered the child is not under any pediatric follow-up, not under any medication. And this was a period of time, there was a gap in our pediatric neurology services because all the pediatric neurologists had left. So together with a colleague, Dr. Nita Sekaran, we pitched this idea of setting up a pediatric developmental clinic to the then director of the hospital and the faculty dean, our Prof Emeritus Tan Sri Muhammad Amin. And he was so very supportive and encouraging. So we started the service. And in the first few years, we ran our clinics alongside the pediatric rehab clinic so that children and their families could get consultation with both teams at the same session, and we could also discuss our management and coordinate our management. Subsequently, when the pediatric neurology service was revived, then we handed over the children with physical disabilities to the pediatric neurologist to coordinate with rehab medicine, and we focused on other neurodevelopmental disabilities such as childhood autism, ADHD, as well as learning issues. So looking back, the main reason we started this clinic was to address coordination and continuity of patient care. But now I realize that this yielded a lot of other positive outcomes. It opened up a learning space for our postgraduate trainees to have better grounding in child development. And this turned out to be really important because subsequently, in both the membership as well as the master's clinical exams, child development was introduced as a compulsory component. It also provided a space for seedlings to grow for subspecialty training, which I'll tell you about in a minute, as well as opportunities for research collaboration. So this very glamorous lady that you see is Associate Professor Subhashini, who, after she completed her master's as a young lecturer, was trying to figure out what subspecialty to do. And she came and spent some time in our clinic and decided to take up training in developmental pediatrics, which she did at UKM as well as in Australia. And she came back to become our first fully fledged developmental pediatrician. And this was really great because with her additional skills, she was able to give our clinic an upgrade into a fully fledged child development center that has the facilities to do more in-depth assessments as well as provide subspecialty training. And subsequent to that, we now have one more trained developmental pediatrician, Dr. Ko Vivian, and two more in training, Dr. Fawaz and Dr. Amanda, our MC for today. So around this time, I also received a request from Associate Professor Lo Siu Yim of Rehab Medicine, who had a master's student, Madam Yi Su Yim, who was an occupational therapist, and she wanted to do a study on sensory issues of children with autism. So we co-supervised Madam Yi, and she was able to produce, very importantly, a validated Malay translation of this short sensory profile, which is an assessment tool, which made it much easier for local therapists to assess their children. And she also did a study which increased our understanding about how sensory processing difficulties affect the childhood occupational activities of children with autism. So from one person who was trying to juggle both the pediatric developmental clinic as well as the scan team, I am pleased to say that we now have 4 people doing developmental pediatrics, and Dr. Kong Sik Tien, who helps me out in the scan team. So the research that I've done on child victimization has been mainly, the ideas for research have been generated by my clinical experience with the children that have been referred to us. And one of the early problems that we saw was of young children, infants, toddlers, and preschoolers who had been abused while they were under the care of child minders or babysitters. And most of these were home-based services which were not registered and sometimes quite often not complying with regulations about the ratio of caregiver to the number of children you look after. What was concerning was that the very young children under 1 year sustained rather severe injuries, such as limb fractures, as well as traumatic brain injury. But there were also these children who said they had been sexually abused by either the husband or the sons of the babysitters. One of the most serious types of physical abuse is what we know as abusive head trauma, which can cause death as well as severe disability. This happens when an adult who's looking after a child, is usually a young infant, is unable to cope with their care needs and may lose patience with their incessant crying. And this can result in violent shaking of the head and sometimes impact of the head against a hard surface, which can cause terrible injuries. So this photograph is a section of a CT scan. The outer rim is the skull. The gray matter inside is the brain. The dark area with the blue arrow is a fluid fill space called the ventricle. So you can see, indicated by the red solid arrows, there is a crescent-shaped area of hemorrhage called the subdural hemorrhage. And indicated by the dotted red arrow, the ventricle on the opposite side is squashed because of severe swelling of the brain, and that whole swollen brain is pushing the brain on the other side. So this is a very, very serious and severe injury. When we look at the follow-up scans, MRIs of the same child 5 months later, you can see that that side of the brain which was injured is shrunken and scarred. So there's actually severe brain injury. And a few years down the line on follow-up, this child had weakness on the left side with difficulties with coordination, speech delay, as well as learning difficulties. So we were able to do this and follow up these children and look at the outcome because we had a facility and a ability to arrange for them to be followed up at our pediatric developmental clinic. Because most of the time, these children, when they are discharged from neurosurgery, they don't return to the same hospital, and nobody knows what happens because they're all dispersed. But we've trained our neurosurgeons to send them back to our clinic. So with this, we are able to actually carry out a series of studies, and some of these are projects of our master's students, which I supervised. So Dr. Ang Siu Chen did a study looking at an 8-year series of 72 cases of abusive head trauma that were admitted to our hospital. And some of the things she found was that more than 3/4 of these children were 6 months or younger, and most of them were in the care of someone else outside the home when they sustained these injuries. The mortality was about 10%, and more than 1/3 were disabled, most of them with multiple disabilities. And if you look at the graph on the right side, so on the horizontal axis, if you go further right, these are the groups of children that have been followed up for longer periods of time after they sustained the injury. And you see that on that side, the bars are higher. So the more time period that you follow these children up, the more disabilities become apparent. And this emphasizes the need to actually have long-term follow-up following these injuries. Dr. Charles Lai, who's now a lecturer in UNIMAS and training in intensive care, did a study where he used a specific assessment tool called the SGS2 to assess the children following this injury more than a year down the line. And what he found was that most of the children, when you actually assess them in detail, were delayed in at least one category. And particularly those who had problems with their hand function, with manipulation, were the ones who had the worst outcomes. So when you looked at their overall development, they are represented in the graph by the little box on the left. Their developmental quotient was much lower than the other group who did not have manipulative delay. And this is something that has not been reported before. So Dr. Uma, whom I'm very pleased to see here, did a study on medical costs, and this was possible with input from Associate Professor Amira Azeri, who's a health economist, because I don't know anything about health economics. Okay, and he found that the median medical costs for severe cases, so these are children who, following the injury, have to be admitted to the ICU and be ventilated and undergo neurosurgery. The medical cost for those admissions was above the monthly income ceiling for our low and middle income households. And this is just talking about the admission. We still have to do the study on what happens and the associated costs with long-term disability. I had the opportunity to collaborate in research about population-based research about child victimization in Malaysia when I was approached by Professor Michael Dunn of the Queensland University of Technology, and he had a Malaysian student who was doing a doctoral thesis on this subject, and I'm sure you all recognize the person in the picture, who's Professor Claire Chu Wan Yen, who after her PhD, I'm very happy to say, returned to Malaysia to serve the Department of Social and Preventive Medicine, and is one of the faculty's top researchers. So she did a study, this was a doctoral study on victimization among secondary school children in Selangor. And subsequently, when she returned, we were able to collaborate on another study about child maltreatment among primary school children. So in the secondary school study, when we looked at those who had more severe experiences of victimization, that means because it was a continuum. So those at the higher end of the continuum who had multiple episodes of victimization, in different categories, this was about 20% of that population, which is actually quite high. And there were about 3% who had experiences of significant physical, emotional, sexual abuse, as well as neglect. So what the study found was that the things which were associated with higher levels of victimization were poor quality parent-child relationships, poor neighborhood and school environments. Now, one of the unexpected findings was that actually the experiences of sexual victimization were similar between males and females. And this is very different from what is reported in the Western literature, which will tell you that most of the victims of sexual abuse are females. So we have significant experiences of this among males, but they're just not talking about it, so it's not revealed because all the focus and attention is on the girls. In her doctoral thesis, it was also found that those who experienced victimization in multiple categories, remember the 3% I talked about, they had a higher risk of various health risk behaviors, such as getting into violent fights, drug and alcohol abuse, as well as thinking about suicide or attempting suicide. Now, from the primary school study, we found that physical abuse inflicted by parents was the most common, and the things that were associated with abuse included parent-child conflict, parent alcohol abuse, as well as poor parent-child relationships, which is a recurring theme that we saw from the secondary school study. Now, we also found that more than a quarter reported physical abuse inflicted by teachers. And children at home who were beaten at home were more likely to be beaten by their teachers. And teacher-inflicted abuse was associated with family conflict and family instability, which we measured by families that moved frequently. The study also found that children who had higher levels of victimization also had higher levels of depressive symptoms. So the interest in technology-facilitated victimization arose when we started seeing a steady stream of teenage girls who were admitted and said that they'd been sexually assaulted after they went to meet people that they'd never met before but had communicated with online. So we did a large secondary school survey of 3,349 children in the Klang Valley and published a report as well as this paper. This was done at a time before smartphones, before there was widespread Wi-Fi access. And even then, we found that the adolescents were already exposed to a range of risky content, which included violent content, hate-inciting content, as well as pornography. These same students said that their parents knew less about the internet than them and did not supervise them much or discuss with them their online activities. And again, you see, we found that the males were the ones who were more likely to meet offline with their online contacts. And overall, out of about 1,005 who went on such offline meetings, about 5.5% experienced verbal, physical, or sexual assaults. We went on to do another study looking at online victimization on social networking sites. So some of the things we found from this study was that boys were the more likely ones to experience online harassment, but there was no gender difference in the experiences of unwanted sexual solicitation. Now, because we also asked them about their perpetration and victimization experiences, both online and offline, we found that those who were harassing other people online and assaulting other people offline, whether it was physically, emotionally, or sexually, were more likely to be victims online. But because this is a cross-sectional study, we're not able to determine which one came first. So I think that the experience of conducting this research has been very, very useful and valuable because it's informed our clinical practice as well as our delivery of education. So, as I mentioned, it was the things that we saw clinically that generated ideas for research. And those findings have actually changed in a way over the years our clinical practices in terms of looking at a wider spectrum of different forms of violence, such as violence in school, inflicted by teachers, bullying, and so on, and also looking for all the associated mental health problems that victims of violence may have. This research, as well as our clinical experience, which has been built up over many years, has contributed to the content of our education towards both undergraduate as well as postgraduate students. And we hope that the students, especially the postgraduate students that we've trained to become pediatricians, will be able to apply this and improve their clinical practice. So in terms of medical education and enhancing professional skills, our postgraduate students in pediatrics are attached to our division of community pediatrics. They go on rotation to different specialties, and they have an opportunity to participate and observe when we actually interview children who have been traumatized, they learn how to carefully and systematically examine and document their findings and to objectively interpret those findings to differentiate between accidental and inflicted injuries, and also to write reports for welfare services as well as the police, and to be prepared to testify in court. They are also made familiar with available support services, communicating with welfare and other support services to get assistance for families. And so this is something that we do in-house, but together with that, because of my involvement as co-chair of the Child Protection Subcommittee of the Malaysian Pediatric Association, we've been able to coordinate and run courses to enhance professional skills of doctors working throughout the country. So this includes not just pediatricians and pediatric trainees, but also those from the fields of emergency medicine, primary care, as well as psychiatry. And we have very, very interactive courses which we discuss around common case scenarios so that they can go through the various steps of assessment and management and all the kind of challenges and pitfalls that one might encounter. Even during the pandemic, we were able to do a 2-part webinar on abusive head trauma. So I'm so very grateful to have a team of very, very enthusiastic people who are always happy to agree to be facilitators at our courses. There are pediatricians who work in the SCAN team, adolescent health pediatricians, psychiatrists, doctors from Obs and Gynae, and we have our legal expert, Dr. Faranini. Thank you so much. So just moving on to some experiences that I've had in regional and international collaboration. So one of the early experiences was running this workshop on cross-cultural issues in child rearing and child maltreatment, which I was able to do with 2 pediatricians, Dr. Shanti Rahman from Australia, who's my virtual twin. We are born a few days apart from each other, and Dr. Deborah Hodes from the UK. And following this, I was able to co-author a book chapter on the subject. In 2015, Dr. Raj Karim gathered all of us together, Dr. Irene Chia, Prof. Claire, Dr. Faranini, and myself, to be the scientific committee of the Asia Pacific Regional Conference on Child Abuse and Neglect. So this was a very good opportunity to get our young trainee doctors to present papers and have an opportunity to learn from international experts, because such opportunities are not easy to come by. I also was invited by the WHO to be part of a panel of experts in a guidelines development committee to develop guidelines for the health sector response to child maltreatment. And more recently, I was a facilitator in the Inspire Masterclass. Inspire is a global partnership to end violence. And in this, we had participants from the Asia Pacific region, and we were assigned different participants to help them work on planning an improvement project to address a child protection issue in their country. I was assigned to this Indonesian participant because we could converse in a common language, and worked on planning a project of having a child-friendly boarding school, specifically addressing the prevention of sexual abuse. So more than 5 decades have passed since the first reports of child maltreatment in this country. What we're doing in the SCAN team is responding to violence after it has already occurred, which is an important thing to do. But as we progress in medicine, we must always move towards prevention and safeguarding. Just like we don't treat people with diabetes only when they turn up with gangrene. We try to have them control their diabetes to prevent that gangrene or to prevent them from having diabetes in the first place, if it's possible. So I'd like to look at this from the view of a well-known nursery rhyme character, Humpty Dumpty. We know this nursery rhyme. What I'd like to emphasize is the last few lines. All the king's horses and all the king's men couldn't put Humpty together again. So when you address a problem, when severe injury has occurred, no matter how much resources you put into trying to fix it at that time, you're never going to get the outcome that, you're never going to restore the person to what they were in the beginning. So what we need to do is to address and try to, reduce the risk of our children who are in risky circumstances, some of which we've identified in our studies, or if they happen to lose their balance and fall, to cushion that blow so that there's no severe injury. This is very important because we have studies and knowledge from around the world, and this is a very important study called the ACE study, or Adverse Childhood Experiences study, that was done on a group of adults in the US who were asked about their childhood experiences of adversity. So adversity included things like living in a family with conflict and violence, having a parent who was a drug addict or went to prison, together with experiences of abuse. So what they found was that those who had cumulatively higher experiences of adversity and abuse had a higher risk of various health risk behaviors, as well as worse physical and mental health in adult life. We also know through the work of David Finkelhor and colleagues that there is a subset in the community of children who experience multiple types of victimization together with social disadvantage. And they tend to be those who have experienced more severe victimization. And they continue to have a higher risk of victimization across the lifespan, and they have a higher risk of psychological distress. Remember that in our own secondary school study, we found that those who experienced multiple categories of victimization had a higher risk of various health misbehaviors. Our primary school children who had higher levels of abuse had higher levels of depression. Now, to try to understand this in a more tangible way, I'd like you to take you through the life trajectory of a person. So this was a teenage girl, less than 18 years, who was admitted following a drug overdose when she tried to commit suicide. So the immediate trigger before that was that she'd been dumped by her boyfriend and she'd just suffered a miscarriage. What was very concerning was that she was living on her own and there was no family in town nearby. So when we unpacked her life history, we found a very disturbing sequence of events. So she grew up in another state and had a father who was a drug addict who beat up her and her mother. And when that father went to prison and the family faced a loss of income, she stopped going to school. And then when her mother acquired a new boyfriend who started sexually abusing her, she ran away and went to a different state. She started working at a burger stall. She met a boy. They became sexually intimate and had unprotected sex, resulting in an unplanned pregnancy and a miscarriage. And that's the point at which we saw her when she was depressed and suicidal after her boyfriend left. So you can see from the beginning, there's adversity, drug addict father, physical abuse and witnessing violence, more adversity with poverty, educational neglect, having to leave school, sexual abuse, and then living with no family support or supervision, all of which result in health risk behavior and medical complications, resulting in a life-threatening mental illness episode. Why it's important to unravel the story and look at the sequence of events is that it helps us to identify and see that there were many points in which, in this child's life, that if she had received the right and timely intervention and support for her and her family, she could have been prevented from going down this path. If she had been rescued from a situation of violence, provided support to attend school and so on. Because while it's important to assist her at the point where she came in, it's much more difficult to address how to help her to live a productive life, how to help her to build a healthy relationship and go on to be a responsible parent. So the journey that we all make is possible because of the many people along the way that have been a part of this, who've guided us and helped us. So I'm very thankful to all my teachers from the National University of Singapore, my mentors in this institution, as well as the Ministry of Health. A big, big thank you to all the previous and present deans and directors of the faculty, as well as the hospital, because I could not do this work without your unwavering support in many, many difficult situations. I'd like to say a very, very special thank you to Tan Sri Prof Emeritus, Prof Amin, who's been always a constant source of encouragement in the many, many times we've met along the corridor over the years. He's never, never failed to say a word of encouragement right up to last week. Thank you, Prof. Amin. Also, a big thank you to all the many departments in this hospital. Of course, my own department of pediatrics and all the past and present heads, but also the different departments in the Child Protection Committee and every department who's either reached out to us when they've noticed that there's a child at risk or who's very willingly provided us with consultation, urgent CT scans, whatever we needed when we told them that there was a child affected because of violence. I'm very grateful for everybody's help and cooperation. A very special thanks to my right hands at different points in time in the SCAN team, Dr. Priya Chandran and Dr. Konsik Tien, and Dr. Irene Chia, who's my co-chair in the Child Protection Subcommittee in the Malaysian Pediatric Association. the real heroes in this story are our medical social workers. So a big thank you to our present head, Puan Fatimang Ladola, and all the medical social workers, as well as many of them who've retired. A few of them have come back today. Thank you so much. And a few of them who we remember in fond memory. Also, thank you to all my collaborators in research, most especially Prof. Claire Chu. Also, I'm very thankful to all my students and all the learning experiences that you give me. And it is through you that I realize that being a teacher doesn't end when you leave the institution, but it's a lifelong role. And I'm so proud of all your achievements. To my family, I'm very grateful for my parents and all they've sacrificed, my husband, my siblings and their families, and my late in-laws and my husband's family. I'd also like to thank the Visibility Unit for all their hard work behind the scenes in planning this event, together with support staff for the Department of Pediatrics. Inche Aizdat, who up to yesterday was, having an episode of food poisoning. Thank you so much. And above all, I thank God for his providence and his protection. I'd like to close with reading you something that has been inspired through my experience of working with children. And this is for all the children in my life who continue to teach me how to listen. And it's called Child to Parent. Speak to me in gentle tones. When you shout, I cannot hear you above my pounding heart. Speak to me slowly, that I may grasp each word, understand, and remember. Speak to me with patience. I need more practice to get this right. Speak to me with your actions. They are a clearer template for me to imitate than all the words you say. Speak to me with words that match your deeds. I get confused when they are different. Speak to me with consistency. How do I learn what's right if it changes each day? Speak to me with your creativity. That gives me the confidence to express my own. Speak to me with music that resonates with the melody inside and makes my heart dance. Speak to me with your imagination that teaches me more than mindless repetition. Speak to me with your approval. It helps me to remember and repeat the things that I did right. Speak to me with encouragement. It strengthens my desire to keep trying. Speak to me with your smile to still the tremor in my hands as I try to carry this without dropping or spilling. Speak to me with your gentle touch. That reminds me that you are near and that you care. Speak to me with your hugs. They ease the hurt and pain more than any medicine can do. Ladies and gentlemen, thank you for your presence and thank you for listening.
Thank you very much, Prof. Mary. That was beautiful. Allow me to share a little anecdote. of my first interaction with Prof. Mary. At the very beginning of my journey in pediatrics here in I was placed in community and developmental pediatrics. And the first patient we had to review together was in the pediatric ICU. And as a junior doctor, these were all the ingredients to make one really petrified. You have the pediatric ICU, and you have a patient with safety concerns, and you have Professor Mary. Right. So she walked into the ICU, and I had read up all the notes about the patient, read everything about the patient, and she comes in, hands clasped behind her back, and she asked me, "So where is the patient?" I said, "Okay, Prof, the patient is on bed 4. And so we walked over to the patient, and she just looked at the patient. And there I was trying to think about all the things that she might ask me. And she just said, "Twinkle, twinkle, little star," in the pediatric ICU. And that was my first ever interaction with Professor Mary. And yeah, ladies and gentlemen, I think it just hit me like that was the kind of interaction that Professor Mary, it's so artful, it is so beautiful and so inspiring. Even when shouldering such a heavy load, she brings to work a blend of humanity, artistry, with quiet sophistication that inspires all of us. And ladies and gentlemen, I would also like to invite Professor Yvonne back up to the podium to summarize and conclude today's inaugural lecture.
Professor Mary, you're just so true to yourself. You spoke of a difficult topic, but with such elegance, respect, dignity, and mindfulness. So, ladies and gentlemen, we have just listened to a truly powerful and eye-opening lecture entitled "Listening to the Voiceless" by Professor Dr. Mary Joseph Marret. She exemplifies quiet strength and enduring purpose. I think her journey from a young medical graduate in Singapore to a nationally recognized leader in pediatrics and child protection reflects a career built on perseverance, compassion, and unwavering commitment. And it's always not about yourself. I was trying to wait and to see whether she would speak something about herself. It's always about others. She has not only shaped the clinical services and medical education in this university, but you have pioneered the developmental pediatrics and championed the child protection at national and international level. So, Prof. Mary, you remind us that resilience is not just about endurance. It is about impact, making an impact. Your legacy is one that listens deeply, acting wisely, lifting others through service, and like how the MC was saying, and pepper it with some music and poem. And I think that's the beauty and how we can connect with the little ones. So your legacy that listen deeply, act wisely, and lifting others shows and inspires that even in the quietest concerns, it can spark powerful change when they are met with conviction and courage. You remind us children are not only vulnerable, but they are individuals with fundamental rights and dignity, rights that are too often overlooked. I really appreciate the poem that you read. I've heard of it many years, and I I do believe that it has touched each one of us in different ways. You have shown us how violence against children may remain hidden, normalized sometimes, dismissed, and how our responsibility as adults is to pay attention to these signals that children give us and to help to break that silence. Challenge the cultural norms that obscure abuse, urging visibility and acknowledging the need for a holistic solution. Her lecture has highlighted the stark reality that the true scale of children victimization is far greater than the cases that we have seen reported, and especially with the new challenges with the technological facilitated abuse emerging in today's world. This highlights the need for interdisciplinary collaboration, as you have mentioned, from healthcare to education and social services. But most importantly, I think, Professor Mary, you have called us to think beyond reactive responses. Protecting children requires a comprehensive approach. Prevention, as you rightly said, rehabilitation, family support, and mental health care, so that the cycle of trauma does not continue in adulthood, and that each of them can contribute to society in the most powerful way. It advocates for systemic reform, emphasizing that legislation alone is insufficient without robust implementation and community engagement. I think your message is truly very clear. If we listen to the voiceless, if we truly listen to the voiceless, we can build systems of care and protection that honor their rights, safeguard their well-being and dignity, and secure their future. Your lecture, though rooted in a Malaysian context, I think this discourse truly aligns with international evidence and calls for shared responsibility in protecting our children. To our dear up-and-coming colleagues, and many of you amongst the audience today, make your journey at University Malaya purposeful and truly count. Dare to step beyond your comfort zone, is what Prof. Mary has done. Not just, come geolocation, moved away. But I think through circumstances, through serendipity, she has gone beyond her comfort zone and channel your concerns. I think in the faculty, every day, we are sensitized to things that perhaps trigger our mind. What can we do further? Channel that and transform that into impactful and meaningful solutions, not just for a few individuals, but for the greater good. So on behalf of University Malaya and Faculty of Medicine, I'd like to extend our deepest appreciation and our highest and heartiest congratulations, Professor Mary Joseph Marret, for your wisdom, dedication, and lifelong commitment to children. Sorry, just to add on a bit more. Prof. Mary, I just have these things to say. Through your conviction, you have been a role model. I can just imagine your sternness, and then she would just melt down that ice, encouraging us to strive, I think, for the ideals. And I think this is a timely reminder for us to go for ideals that resonate us. You have reminded us today, in your own powerful way, to reconnect and rediscover the purpose of why we are here today, whether be it in the faculty, in the university, in Malaysia. We have a purpose, and that fire of passion and dedication. Thank you so much, Professor Mary, So ladies and gentlemen, once again, please join me in thanking Prof. Mary.
Thank you again, Professor Yvonne, for chairing this inaugural lecture. And thank you, Prof. Mary, for such an insightful inaugural lecture. So ladies and gentlemen, this concludes our event for today. Thank you for sharing this remarkable moment with Professor Mary Joseph Marret. And to commemorate today's event, we'll be having a photography session with Prof. Mary. And we will start off with Prof. Mary and Prof. Yvonne on the stage. All right, next I would like to invite both Prof. Mary and Prof. Yvonne to join the audience for a group photograph. If everybody would want to come closer. Maybe everybody from the back as well, if you can come forward. And, stand up, yeah.